Hello, good morning, good afternoon, good evening po sa lahat. Welcome to the 135th 135 episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who have just discovered us for the first time today, welcome po at sana po masiyahan po kayo at marami po kayong matutunan sa araw na ito. For several months now, sporadic increases in dengue cases in the community as well as hospitalizations have been reported in the news. Philippines is one of 100 countries where dengue is endemic, and dengue, as you know, is a viral infection transmitted to humans through the bite of infected mosquitoes. Primary vectors that transmit it are Aedes aegypti mosquitoes and to a lesser extent, Aedes albopictus mosquitoes. The global incidence of dengue has grown dramatically, with about 50% or half of the world's population now at risk. The dengue incidence has increased 30-fold, 30 po, in the last 50 years, with geographic expansion to new countries and more recently from urban to rural settings. Although estimated po 100 to 400 million infections occur each and every year, mahigit 80% po are generally mild and asymptomatic. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And always looking forward to our Fridays because I get to share hosting duties with our adjunct research faculty at the National Telehealth Center, also internationally renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie?
Hi, good afternoon, Raymond. Magandang hapon po sa inyong lahat. We would like to greet all of you who are here with us in Zoom and those of you who are watching on Facebook Live, TVUP's YouTube channel, and all of you who are also watching us on Signal TV channel 101. So I'd like to greet all of you, and of course, all of you who are watching on the playback. I think also for this webinar, we will all want to watch the playback because we've got a great set of speakers who are going to talk about very important problem we're facing in public health, which is dengue. So we will talk about clinical management and early diagnosis of dengue and what are the updates on this. And there are 4 case scenarios and a detailed explanation of how cases were managed and could have been done based on new guidelines. So apparently there are guidelines on dengue that may not be reaching the ground. So we've got Dr. RONTGENE Solante, you know him, he's been with us before, chairman of the Adult Infectious Disease and Tropical Medicine Unit at Lazaro Hospital. And he will be talking about clinical management. And then to look at the health financing angle, we have one of your favorites, Dr. Albert Domingo, Director 3 of the Health Finance Policy Sector of the Philippine Health Insurance Corporation. So we will talk about the case rates for dengue under the National Health Insurance Program. And we might have an additional guest. So let's see if we have one more guest coming in. As you've noticed, we are not just talking about COVID, but also talking about other infectious diseases. And like today, we're talking about dengue, which is part of, sabi natin, COVID, other outbreaks, viruses, dengue sa virus, infections, and disasters. And we know that you always want to be updated on the news, and it's for this reason that we bring you the news update.
Okay, for our very first news update, metformin, yung pong ating diabetes drug, as you all know, recently has been linked to reductions in COVID-19 viral load. Treatment with the diabetes drug metformin shows a significant dose-dependent effect in lowering SARS-CoV-2 viral load within days of administration. Ito po ay ayon sa latest analysis of the Phase 3 ng COVID-out na trial. And these findings add to a multitude of benefits that the drug has been shown to have as it pertains to COVID infection. So more recently, I think around mga August of last year, metformin was found to lower the odds of emergency department visits, hospitalizations, and deaths due to COVID-19 by more than 40% and over 50% if it is prescribed early during the onset of symptoms. Ito rin po ay ayon po sa COVID out trial, and this finding po was published in the New England Journal of Medicine, and the study was led by University of Minnesota Medical School and School of Public Health, and with one of the sites po kasi was Northwestern University Feinberg School of Medicine in the trial. The study also found no positive effects from treatment with those other drugs that you have known, such as ivermectin and low-dose fluvoxamine po. But really, very important to note that something as, let's say, safe and common and inexpensive as a drug for type 2 diabetes can have significant effects in lowering COVID-19 viral load. Dr. Susie?
Yeah, thank you so much, Raymond. Well, we have news from several sources, and I saw this a couple of days ago, that public health experts are warning the public about big sodas alcohol drinks. So apparently there are now products like this one that you want to see on the screen, which is called Hard Mountain Dew. So we know Mountain Dew to be a soda, and it says here 0 sugar, so you think it's just an ordinary soda, but actually it contains alcohol. And this can be quite deceptive. It's creating a new category for drinks that are thus far unregulated. And it's really troublesome because you might drink this and drive a car and think, well, I was drinking Mountain Dew, but actually you were drinking something with alcohol in it. So we will continue to monitor this. There are several products that are out. Another one is called the Beast Unleashed. Mga ganyan, ano? They're marketed as soda, but they actually contain alcohol. So these are some of the news we have this week, and next week we'll bring you more on the news update. Okay, for our webinar topic today, global incidence of dengue has grown dramatically with about half of the world's population at risk. And some are saying that this has been an effect of changing climate, that this vector is now, able to live in cooler conditions. And there are an estimated 100 to 400 million infections each year. Now, 80% of these are generally mild and asymptomatic. And we know that there is no specific cure for dengue, but if diagnosed early and managed properly, dengue need not result in death. So Raymond, what we're going to do first is we're going to ask some persons on the street what their experience has been on dengue, and please go ahead with that.
So for those who are joining us for the first time, we always set our discussion into context by watching this short video of the common folks on the street being asked questions. And for this week, the questions that we pose to them, nagka-dengue na po ba kayo? Ano po ang karanasan ninyo sa dengue? Paano po kaya maiiwasan ang pagkakaroon ng dengue? At nabalitaan nyo na po ba yung 4 o'clock habit? At sa tingin nyo po ba nakamamatay ang dengue? Please watch this.
First off, oo, nagka-dengue na ako. Pero matagal na siya. I was in grade 8.
To answer the question, yes. Nagka-dengue na po ako around, I think 3 years ago, 3 to 4 years ago. I'm not exactly sure, but it's been a while.
Nagka-dengue ako nung college pa yata. Medyo matagal na.
So yes po, nagka-dengue na ako back when I was 9 years old.
Yung experience ko, syempre, I miss a lot of academic requirements. Yun talaga yung pinaka-iconic na nangyari sa akin. And yung parents ko din kasi, they had to take care of me. So medyo nahirapan sila na ganun kasi they had to miss work then.
I got hospitalized kasi sobrang, alala ko parang nahilo nun eh. And then, I think the red blood cells or something. Something about the cells, the blood cells.
Parang ilang days na akong high fever. Tapos, dinala na ako sa infirmary. Tapos, mababa na pala yung platelet count ko. Parang super baba na pala.
Nung nagka-dengue ako, I feel like it was kind of deadly kasi nanghina ng todo katawan ko. Yung temperature ko, it rose, I think, almost close to 40 degrees. And I was admitted to the hospital for like 7 days.
Yes, feel ko nakakamatay ang dengue kasi no joke talaga siya na meron akong mga kakilala na nagkaroon na din ng blood transfusion. Although ako naman, personally, hindi ako nakarating sa ganung point ng dengue. Pero, which is good. Pero yon, my sister, nagkaroon siya ng dengue before and umabot siya doon. So definitely, I would say yes, nakakamatay siya.
And I think it's not that deadly. Taking in if you have the right precautions like enough exercise and enough hydration.
Sa bahay, dapat walang makikip anywhere, and dapat ma-check lagi and i-throw out kung kailangan na siyang i-throw out, kasi I remember na dun talaga nag-grow yung mga lamok.
Something that you could do to avoid dengue is to always keep clean waters around you. Like kung nag-iigib kayo ng tubig or like para sa ulan, like always keep that closed or at least sanitized, parang ganun.
Actually, hindi ako familiar sa 3 o'clock habit.
Yung 3 o'clock habit, ito ba yung yung stop, look, and listen? Parang mag-stop ka ng 3 p.m. tapos maghahanap ka ng mga possible breeding ground ng mga lamok, tapos lilinisin mo. Tapos yung listen yata ay makinig sa mga announcement, mga health announcement.
And also yung mga drainage system, this is an institutional problem, or like sa buong gobyerno, yung drainage sa Pilipinas, I think it should be fixed kasi syempre merong mga kanal and then doon nag-grow din yung mga mosquito, so dapat maayos siya para ma-prevent natin yung dengue sa buong bansa, hindi lang personally.
Okay, thank you so much to TVUP for those insights, and Raymond, na dami sa kanilang nagka-dengue na, no?
So, they're very young.
Very young.
I personally have not had dengue, Dr. Susie, but from what I hear, it's very dangerous po, no?
I had dengue, Raymond, when I was a second-year medical student. Lima kami nagkasakit, and it was really terrible. It was, it's really a very bad disease to have, no? So anyway, we'll talk about that a little bit more later, but I think you've got some housekeeping, and then we will talk fun quiz.
Yes, a little bit of housekeeping po for all those who are asking. Certificates of attendance will be given to those who watch at least 50% of the webinar duration. We have already completed the sending of the certificates for all 133 webinars. For webinar 134, we are still completing it. And for those who are asking just before webinar 134, so 133 and below, if you have not received your certificate, please email us at stopcoviddeaths@up.edu.ph so we will check our records po. For our webinar today, we'll be having a standard panel discussion format. Our main speaker will present until we hear from our reactors po, followed by a Q&A session. But before we delve into the webinar, let's have our cute intro video for our fun quiz segment.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Ay, nako, Raymond, nakakatawa pa rin yung mga rabbit na yan. Okay, sige. So let's go to our fun quiz.
Thank you so much. Thank you so much, TVUP. We have the I'm not seeing the Zoom pop up. Maybe I'll need to. Do we need to relaunch the poll? I'm not seeing po kasi Can we launch the poll here in the? Thank you so much.
Yun.
So for those who are joining us outside of the Zoom, as mentioned, you can still participate in our fun quiz by opening up your internet browsers, typing in slido.com and entering the code 6510096. That's 6510096 for you to be able to participate in our fun quiz. We have three questions for today. The first question, how will you confirm dengue? Is it through clinical diagnosis, so history of fever, headache, rashes, or is it through presence of thrombocytopenia? Yung po yung pagkonti po ng inyong platelet sa inyong dugo. Number 3, dengue IgG and dengue IgM. Ito po yung mga tests na ginagawa po pag may nagkakaroon po ng dengue. Or is it through NS1 antigen? Or finally, the fifth option, all of the above, lahat po ng nabanggit. We'd like to greet those who are joining us again. As you see on the chat, Las Piñas General Hospital, maraming salamat po. Those from Aliaga, Nueva Ecija Local Government Unit, Southern Isabela Medical Center in Santiago, Isabela, the UP Los Baños CEAT, Department of Chemical Engineering, maraming salamat po, Los Baños, Laguna, University of Mindanao in Davao City, Tombok Salayog Hospital in Tacurong City in Sultan Kudarat, thank you so much. Escalante City in Negros Occidental, may mga nanonood po. Emilio Aguinaldo Memorial Hospital, which is in Cavite. Rizal Medical Center din po. Those from, let's say from Southern Philippines Medical Center, all the way din po, pinanonood po tayo from Narvacan, Ilocos Sur. Obviously, we have those from Davao, from our regulars from Isabela, the regional office of Tuguegarao. Maraming salamat po to our avid tagapanood at taga-subaybay po, no? Those who are joining us obviously from, let's say, from Bataan, marami po nanonood niyan, and from the University of Santo Tomas. Thank you po. Question number 2, which of the following are warning signs of severe dengue? Is it A, gum bleeding? Is it B, headache? Is it C, abdominal pain? Or is it all of the above? Internationally, you also see in the chat po, no, we are being viewed by those from the University of Al in Saudi Arabia. Maraming salamat po. From the Saigon International College, Ho Chi Minh, Vietnam. From Chonin Hospital in Taipei City in Taiwan. From Bangkok, Thailand. From Penang City in Malaysia. Oman College of Health Sciences in Muscat, Oman. And from Lunichi Ali University of Blida II in Algeria. Maraming salamat po. And for our final question for the fun quiz, how will you prevent mild dengue from progressing to severe dengue? Is it A, immediately identify warning signs? Letter B, make an immediate decision to admit. Letter C, test nyo po muna for thrombocytopenia pag konti po ng platelets. Or letter D, lahat po ng nabanggit. We will not yet close po ito pong mga fun quiz po natin. No? I know there are those who will still want to participate as we move on to our webinar proper. Dr. Susie?
Yeah, thank you so much, Raymond. We're going now to our main speaker. And he's not new to you. In fact, he was one of our first speakers when we started talking about COVID and dengue. So we'd like to give a warm virtual welcome to Chair of the Adult Infectious Disease and Tropical Medicine Unit of San Lazaro Hospital, Dr. RONTGENE Solante, who will be giving us a video lecture, but he's going to be with us. Actually, he's with us, and he'll be with us on the Q&A. So let's welcome Gene Solante. Welcome, Gene. Huwag may palakpakan ba? Palakpakan naman.
Good afternoon, everyone. And first of all, I would like to thank Dr. Susan Pineda Mercado for this invitation to talk about updates in the clinical management of dengue. Now, the objective here is we'll review the clinical management of dengue from early diagnosis to anticipating complications related with plasma leakage, bleeding disorder, and other related events during the time course of the infection. So I'll start with this first slide that Philippines has always been a country considered as a threat for any increase in the number of dengue cases. Having this important data that makes us a high level of endemicity. Aside from having the 4 dengue serotypes that is co-circulating in our country, the transmission has been documented all year round, and there are months that, in fact, even before, from 2003 up to 2013, that during rainy season, cases are really higher than expected in some of these months, and that's what also we have experienced now in most of the data coming from the Department of Health. And in terms of the vulnerable population, anyone is vulnerable, but I think most of those that are highly vulnerable are those in the less than 25 years of age. And at the same time, it means that higher cases is also expected with this group of population. Now, I would like to specifically mention that in 2020, the WHO was able to document that Philippines is one of those countries with the highest number of dengue cases during the 2019 surveillance. And it was so high that there was a documented 86% increase in the cases. And, and based on this data also, there was also a higher mortality rate and a higher case fatality rate. And that's the reason why that with this administrative order of the Department of Health, there were addendum to the revised dengue clinical case management because of some findings by the WHO mission report in 2018, wherein one of the important or major gaps in the management that somehow contributed to the increase in the mortality is also the delay in the institution of appropriate therapeutic modalities. And there was also a significant finding there that part of that is also the fluid or the overhydration among patients is one of the causes of the mortality. And that's why the objective of this administrative order of the Department of Health is to really update the clinicians and make an informed standardized protocol among these clinicians, whether you're working in the government or any private health facilities in the diagnosis and treatment of dengue. So I would like to share with you, these are the three most common findings in terms of the causes of mortality by the WHO during the 2018 mission report. Aside from the delay in presentation to the healthcare system, resulting in delayed admission and delayed institution of appropriate rehydration, where the culprit here is upon admission to these tertiary centers, most of the time patient is already in the severe form of dengue. And there is also delay in instituting appropriate rehydration measures, so which means that at the site of the hospital admission, there was also gaps in terms of fluid hydration. And the third most common cause of mortality is also fluid overload. So in this particular report, they emphasize the following in terms of how we can alter and decrease the mortality. And these are important measures that we always have to take into consideration when we're looking up a patient whom we suspect with dengue. First is the early diagnosis and indication for admission. Second is early detection of plasma leakage and what we call time-sensitive institution of fluid rehydration in order not to give also too much of your fluid to prevent fluid overload. Third is the investigations and correction of common complications in case patients do not respond to conventional IV fluid therapy. And then fourth is early detection of bleeding and early blood transfusion. And then the last is early diagnosis in cases with unusual manifestations, especially those with encephalopathy or the presence of comorbidity or the presence of another superimposed bacterial infections. And that's why in 2020, the Department of Health formed a technical working group in order to review some of these gaps in the management of dengue. And more or less, there were changes in this clinical management, and that's the one that I will focus in the discussion this afternoon. And I would also like to share one of the major changes also in the approach to dengue management is the incorporation of innovative diagnostic modalities. And we're talking here about the dengue NS1 antigen rapid diagnostic test, which somehow will help us diagnose a patient with dengue. And I think this has been implemented in the primary healthcare setting, that it should be readily available so that if a physician will suspect that patient is dengue, then you have a very good diagnostic tool to confirm it at the level of the primary care center. Now, for us to better understand the clinical manifestation, the stage of the infection, and at the same time to anticipate the presence of what we call severe dengue, the WHO revised the clinical dengue classification in terms of how patients will present and to anticipate what are the warning signs that will enhance the risk that this patient will have severe dengue. So we now have the dengue with or without warning signs. So here you have the criteria for a probable dengue. So you have any of those symptoms in the form of fever plus two of the following criteria. So that's probable dengue. Now, if it is confirmed by an NS1 antigen test, then that is laboratory confirmed dengue, presence of these clinical manifestations. So what is important here is that clinicians should be aware of the warning signs. Why? Because when a patient presents with any of these warning signs, then that is where we can strictly observe and this particular patient, closely monitor them, and at the same time intervene the appropriate medical interventions in order to prevent severe dengue. Because once you are in the severe form of dengue, then the risk of mortality and progression further, especially for higher mortality rate, it's very difficult to revert this, and they're already in the severe form of dengue. So these are the warning signs that has been elaborated, that any of the signs will have higher risk that this patient will go into severe dengue. First, you have abdominal pain or tenderness, persistent vomiting, you have clinical fluid accumulation in the form of pulmonary or pleural effusion or form of fluid in the abdomen. Then you have any form of mucosal bleed that's already considered a warning sign. Patients presenting with restlessness or lethargy, liver enlargement more than 2 centimeters, which means you have also hepatic decompensation because of the severe form of the infection. And then laboratory-wise, you have to also monitor the hematocrit and the platelet count. And here, a warning sign is if your patients continue to have an increase in the hematocrit, and that's why it's very important that when you are getting CBC, especially for outpatient clinical management of dengue, the hematocrit and the platelet count are two parameters to tell you that your patient is stable or with warning signs. So, which means that if there is rapid decrease in the platelet count and increase in the hematocrit, then that's already a sign of a possible plasma leakage or a bleeding disorder. And then when you have patients with severe dengue, you also will classify them if the severity is due to a severe plasma leakage. That's why these are patients who goes into hypotension or with fluid accumulation associated with respiratory distress. And then the second is because of severe bleeding, and because of plasma leakage and severe bleeding, there's also a concomitant severe organ involvement. And this is manifested in the form of a high elevation of your SGPT and SGOT, which at times, based on actual experience, if you have a patient with more than 1,000 international units, whether it's the SGPT or the SGOT, then that's already a portent of things that the patient already have some form of organ dysfunction. And more so if the patient have impaired consciousness, and at the same time patient is tachycardic and presence of hypotension, then these are part of what we call multi-organ dysfunction. Now, to better understand also that anticipate some of these important clinical manifestations, we need to understand that when we have patients with dengue, the clinical manifestation and the course can be either in the form of a non-severe dengue, where most of these patients fever subsides on the 4th to 7th day of the infection, and then they will spontaneously recover. The platelet count will normalize from the 5th to 7th day, and then eventually the hematocrit also will normalize up to the 10th day. But in some patients, like patients who are going to severe dengue, especially with warning signs, it seems that you need to closely monitor them, starting at day 3. If the patient continues to have fever, it doesn't mean that the patient is still in the febrile phase, because in some patients, febrile patients will still have fever up to 4th to 5th day, but already there is an ongoing plasma leakage or severe hemorrhage or even organ impairment. So anticipating the possibility of dengue in terms of during the critical phase is really important, because before this will occur, then you have to institute appropriate measures in terms of appropriate hydration, anticipating for the presence of compensated shock, and before anything that is related with leakage and severe hemorrhage will set in. And once this complication, like if you have patients with plasma leakage or severe hemorrhage, then it's also important that you need to know what important steps you will undertake in order for you to prevent this patient from mortality. And if you'll be successful in preventing and correcting plasma leakage and severe hemorrhage, then during the recovery phase, you also need to watch out for those individuals that on IV fluid for fluid overload or resulting to acute pulmonary edema. So this particular article by Kalaya Naruz, which examined and reviewed some of the important causes of higher case fatality rate in some Asian countries, is being driven by what we call specific problem that is related with high case fatality rate and specific solutions also. So I will be talking about each of these problems, and we'll be doing some sample cases so we can more or less relate what happened to the patient, and at the same time we will know what particular intervention is important at that instance when you have this specific problem. Okay, so the first case scenario here is a patient came in for consult and was diagnosed with dengue. So meaning patient has clinical manifestations of dengue, and at the same time he was already confirmed with dengue, but was advised to go home for home care. So meaning most likely this patient only have some mild form of dengue, and later came back and became a severe dengue and died. So what should have been done in this particular patient? So one of the common problems that we always encounter is the improper diagnosis and triage of dengue. And somehow this will lead to delayed diagnosis of dengue, and in some patients can proceed to severe dengue. And that is why it's important for clinicians to early to recognize the presence of dengue, and at the same time look for some of the warning signs. And these warning signs will somehow educate the patient, will educate the clinicians to anticipate that the presence of these warning signs, they should be appropriately managed. So the most important steps here is always suspect dengue in any patient presenting with fever, obtain a CBC, look at the hematocrit, look at the white cell count, look at the platelet count. And during this time, they also encouraged to perform tourniquet test, because presumptive of the diagnosis of dengue, when you have a positive tourniquet test, then that's highly suspicious that your platelet count is already deranged. Now, a positive tourniquet test and leukopenia increases the suspicion of a patient with dengue. You educate the patient regarding warning signs before you will tell them to go home, especially for those only with mild symptoms, and give them a specific instruction on when are they going back to the center as much as possible. If they can give you feedback every now and then, every day for the patient, it's also important to take that into consideration. Daily follow-up with CBC in suspected dengue cases, especially from day 3 of illness onwards, also helpful because you want to anticipate that at this point in time, probably patients will be in the critical phase, anticipating on the entry of the critical phase of dengue, which usually starts day 3 up to day 6 to day 7. And of course, for us to really document that they have dengue, if it is available in your hospital, in the local health center, then obviously do a rapid diagnostic test, which will help you identify and confirm the presence of dengue. So in this particular patient, as we have mentioned, this patient was sent home because only of a mild presentation, but later came back in the center, in the hospital, and became a severe dengue and eventually died. So this is where that clinician should have a better understanding of the course of illness. Remember that shock, bleeding, and organ failure can already start at day 3 or 72 hours from the onset of symptoms. So they may initially present with mild symptoms, but on day 3 or day 4 of the illness, they should be closely monitored. And as much as possible, uh, they have to monitor the patient. If the patient continue to be weak looking, cannot tolerate oral fluids, and cannot produce good urine output, then there's already an element there that your patient is already in the plasma leakage stage. So you also need to understand that there are specific individuals at higher risk for severe dengue. And these are the younger population, the elderly population, and those individuals with a lot of comorbidities. So these are individuals whom you have to really carefully and closely monitor. And as much as possible, if you have these patients in terms of closely being monitored, then you can advise them to be admitted in the hospital or in a primary care center or a secondary care center before the third day of fever for close monitoring. Now, I would like to share this important impact of misdiagnosis and in relation to severity. And one of the important findings of the WHO then was the misdiagnosis in terms of it's one of the more contributing factors on dengue mortality in the Philippines. So what are the causes of misdiagnosis? One is that a physician is declaring that the patient has no dengue because of a normal result, no? Normal CBC result, especially during the first 24, 48 hours, the first 3 days of the infection. You may not find any abnormality in the hematocrit or in the platelet, and that's why it's very important that in those first 3 days, you just don't consider them being normal as having no dengue. Second is declaring that the patient has no dengue because of a negative NS1 test. No? There are cases also that even if they are confirmed dengue, remember the sensitivity and specificity will also vary in terms of the number of days from the time that they have the infection, or in some patients, there are those who really are NS1 negative but are having clinical signs of dengue. So that means that a negative NS1 test doesn't totally rule out the absence of dengue. Third is declaring that the patient has no dengue because there are no rashes. And I think this is also common, no? The misinformation that some parents or some relatives are alluding to, that they always correlate dengue with the presence of rash, or what we call the viral extensem. No? And in fact, rashes will only occur in around 30 to 40% of cases. And usually the appearance of rashes, what we call the Hermann's rash, is only part of during the recovery phase of the dengue. And in some severe cases, rashes can occur during the 48 to 72 hours, which means that even if they are not yet in the recovery phase, rashes can also be present. But again, the absence of rashes cannot just be discounted as, or cannot just be counted as the absence also of a dengue. And then the other cause of misdiagnosis is patient has no dengue because laboratory results showed a different diagnosis. Remember, and when a patient have a viral infection, sometimes even the urine will have increase in the fat cells, no? And we encountered a lot of that in our patients, that initially they're treating them for urinary tract infection, and they are sending them home because the urinalysis has fat cells, no? So the presence of your fat cells in dengue doesn't mean it's urinary tract infection. Because of a systemic nature of dengue, it can also cause some abnormalities in your urine. And chest X-ray can also be abnormal in some patients with dengue because of the possibility that it can also have complications in the lung, and that's why they can also present with pneumonia. So the bottom line here is that all patients with fever must always be thought of as dengue until otherwise proven that it is not dengue. So my second case scenario here is that this patient was admitted in a small hospital and later transferred to the tertiary hospital, but still died. No? So the question then is that, why did the patient die when this patient was already in a tertiary hospital? Is it a form of transferring this patient? It's because during the transfer, the patient is already hypotensive, or upon admission to the tertiary hospital, there was also lack of apparent impression that the patient is already in the form of beginning to have the plasma leakage or capillary leakage, and the attending physician was not able to identify that, because the blood pressure, the heart rate are still stable. So these are some of the gaps that we have encountered. So it's important that the key to a safe referral of a dengue patient is that the first hospital was able to foresee the possibility of a shock or organ failure prior to the referral. So which means that before transferring the patient from a small hospital to a tertiary hospital, there should be institution or implementation of appropriate hydration so that that patient is already stable before being transferred to a tertiary hospital, because lack of that particular awareness, which means that during the transfer, it can be possible that when the patient develop a hypotension already in the first hospital prior to the transfer, there will be higher chance of mortality compared to those transferred without any hypotension yet. No, and again, this entails a very important observation, clinical acumen of the clinician to monitor the patient before being transferred, especially for patients that are already borderline hypotensive, but the patient or the patient still manifesting with a normal hemodynamics, but there are already signs of what we call compensated shock. And that's the reason why monitoring is really vital before transferring the patient to a tertiary hospital. So in this particular article, in the case management of dengue, second is the second most common cause of increased case fatality rate is the improper recognition and management of plasma leakage. Okay, so this improper recognition and management will somehow either result in delayed fluid resuscitation, and at times, if you see that the patient is already hypotensive, you also do a lot of this fluid management to the point of fluid overload. So what is important here is that when you give fluid to your patient, especially during the plasma leakage, you have to have what we call optimal fluid management in order to address the plasma leakage during this febrile and critical phase. So the bottom line here is, number one, avoid unnecessary intravenous fluid during the febrile phase. Second, limit intravenous fluid during the leakage phase to maintain urine output. And this is where urine output will be very important in terms of adequacy of hydration, because if the patient is properly hydrated, then you also have a very good urine output. But if you push and push your fluid, and despite pushing your fluid, there is no urine output, then there's a possibility that at that instance, there is already renal dysfunction. And sometimes that can also lead to fluid overload. And more or less, the choice of your fluid should be critical in terms of hydration. So here, when the patient will have signs of plasma leakage, you use a hypertonic colloid or plasma volume expander when response to crystallized infusion is insufficient. Why hypertonic colloid or plasma volume expander? Because these are fluid that can enhance your intravascular volume. Okay, so that means that less of the extracellular volume will be expanded, because when you have extracellular volume expanded, you run the risk also of acute pulmonary edema. No? And this is where most patients will benefit with a colloid or a plasma expander at the expense of a patient that is hypotensive and you keep on pushing your fluid to the point of fluid overload. And at the same time, during the recovery phase, there is also recognition and management of volume overload during that phase, because at times clinicians has some difficulty of really identifying patients during the critical phase and that of the recovery phase. That even up to the recovery phase, when they see that the patient's platelet count is still low, they will always push and push fluid. No? Remember, there is also resorption phase, wherein the fluid that you give during the critical phase will also go back to the extracellular fluid, and further increase in the volume will also cause acute pulmonary edema or volume overload. And this is where you will need to diurese the patient. And if the patient will have hypotension, then you need to be ready with your colloid in order to maintain that extra or intravascular volume. The third scenario here that can increase the case fatality rate is improper recognition and management of bleeding. So remember, dengue cases or dengue patients will have severe dengue either in the form of plasma leakage, or you have also bleeding, because bleeding is also part of your dengue because of the derangement of the bleeding parameters. And that's why some patients will have significant hemorrhage. And because of this significant hemorrhage, there are the center has what we call delayed blood transfusion, and it will also lead to mortality. So at this point, when there is the possibility that your patient is already bleeding, aside from plasma leakage, you need to identify if this patient's decrease in blood pressure is really or is secondary to plasma leakage or secondary to an actual bleeding or both. No, so you need to maintain a high level of suspicion for occult bleeding in severe cases. So usually, this is manifested in the form of shock without hemoconcentration. So meaning the patient's high blood pressure continues to be in the hypotensive side, and your hematocrit is also going down instead of hemoconcentration. And most of the time, if there is already occult bleeding, there is also associated manifestation of severe abdominal pain, abnormal vaginal bleeding, and or the presence of bloody urine, especially in patients with thalassemia or G6PD deficiency. Now, the presence of severe abdominal pain heralds the onset of possible intra-abdominal bleeding, and that's always the case that we experience and actual experience, that when they have severe abdominal pain, there is rigidity, the form of in the form of acute abdomen. Then that's already a sign that your patient has intra abdominal bleed. So you need to really be you have to recognize the signs and symptoms, or even before the signs and symptoms. And usually it is in the form of a decreasing hematocrit at the expense of a decreased blood pressure. So you optimize your transfusion practice, give transfusion in the form of an RBC or a packed RBC or a whole blood if the patient's hematocrit is really going down, especially for hematocrit of less than 40% to less than 45%, and the patient is hypotensive. No? So these are important parameters wherein you are already in the form of active bleeding. Okay, and at this point, we always inform the clinicians that when patients' hematocrit is going down and at the expense of a decreased platelet count, then chances are a lot of the clinical practitioners always transfuse platelet. No, so we limit. No, we should limit the use of platelet transfusion, because the problem there is not about the platelet; it's really about the decrease in your hematocrit because of the volume that is related with the occult bleeding. So another case scenario here is number 3, patient admitted in the hospital initially with a stable vital sign, and then intravenous line was initiated, but still the patient developed shock despite of the early admission and early administration of your intravenous fluid for hydration. So what's the problem here? Did we miss something here in this particular patient in terms of recognition that the patient is already in the compensated shock, or did we appropriately give the IV fluid that is appropriate at this point in time? Okay, so when you manage a patient like this, remember that giving IV fluids is not enough, no, because some dengue patients need more fluid due to the plasma leakage. So it's important that at this point in time, when you are when you have a stable vital signs and you are starting IV line, you need to monitor also the urine output. Okay, you don't want patient to be giving IV fluid and yet your patient's urine output is going down, that means you're not properly or adequately hydrating the patient because of ongoing plasma leakage. You also examine the pulse pressure. If the pulse pressure is narrow, meaning you have a diastolic pressure, increasing diastolic pressure at the expense of a stable systolic pressure, patient is tachycardic, and then when you look at feel the pulses, it's faint and thready, and then the capillary refill time is more than 2 seconds, then these are already signs of massive plasma leakage. So good monitoring should have been done to guide the doctor to increase the fluid. Okay. So at this point, I would like to show you this scenario that from stable circulation and you have a patient with compensated shock, it's important for us to really recognize the presence of compensated shock, because before a patient will go into a hypotensive shock, there will always be signs of a compensated shock that you need to intervene so that you will prevent this patient from going to a hypotensive shock. Okay. So remember, patient can go from a stable circulation, so meaning the patient is conscious, the capillary refill time is less than 2 seconds, extremities are warm and pink, and the peripheral pulses are good, and then heart rate, blood pressure, RR, and urine output are normal. Okay. Now, if left uncorrected, then they will develop what we call the hypotensive shock. So in most of the scenario here, it is common practice for clinicians to wait for a clear hypotension or a drop in the blood pressure before doing a fluid resuscitation, such as the use of your crystalloid bolus. No? So in this particular time, we would like I would like you to focus on this compensated shock, because during the time that these patients are already in the compensated shock, the blood pressure are normal. But if you notice, you have to get the pulse pressure. So you have a normal systolic pressure, but the diastolic pressure is rising. So which means that if the interval between the difference between the systolic pressure and that of the diastolic pressure is less than 20 millimeter mercury, especially in children, and you try also to do what we call let the patient sit up and then get the blood pressure while sitting up, and then get the blood pressure while lying down. If there is postural hypotension, if the blood pressure upon sitting up is lower than that compared to if they are lying down, then there's already what we call a compensated shock. And most of the time, this patient's consciousness level is still clear and lucid, no? And they manifest already with tachycardia, the peripheral pulses are weak and steady, and there is also cool peripheral pulses. This is sometimes missed by a clinician, that your patient is already in the compensated shock. And patients in the compensated shock are the ones that we need to intervene in terms of fluid management, because this is already the beginning of your plasma leakage. Okay, so here it's important that when you are when you have already signs of compensated shock, you have to give your crystalloid bolus, even if the blood pressure is not yet in the hypotensive level, in order to prevent organ failure. Because waiting for a hypotension before doing fluid resuscitation measures might be too late. No, so this is the importance why we need to closely monitor these patients when they are admitted and look for signs of your compensated shock, because that's also the time that your patient is already in the severe plasma leakage, and up to the point that if you will not be able to hydrate this patient properly and adequately, then they will proceed to your hypotensive shock. Okay. And most of the time, they will have the manifestation of restlessness, very combative. You have a patient that is feeble or absent peripheral pulses. Your heart rate is in the line of 110 to 120 in some patients, or in some patients that are already in severe form of sepsis, they may present with bradycardia, and the blood pressure is hypotension. And that's where some of these patients will really die because of irreversibility at this point in time. At the same time, they will have severe metabolic acidosis. So I would like to share with you this algorithm on how to approach a patient with compensated shock. So if you see that your patient is already in the compensated shock, you start your isotonic crystalloid at 5 to 10 ml per kilogram per hour and run that for 1 hour. Okay. At the same time, you also give oxygen support. Now, if there is improvement, then subsequently you lower your IV crystalloid to 5 to 7 from a 5 to 10 for 1 to 2 hours. And then if there's more improvement, you lower it to 3 to 5 ml per kilogram per hour for the next 2 to 4 hours. And again, if the blood pressure is stable, the heart rate is going down to normal heart rate, and the pulses are more or less good, then you maintain the patient at 2 to 3 ml per kilogram per hour for 2 to 4 hours. Now, as clinical improvement is noted, then you further reduce the fluid accordingly, and you only give further boluses if needed. And after 48 hours, you may stop the IV fluid to prevent fluid overload. Now, in the event during this form of the compensated shock, and you give your isotonic crystalloid of 5 to 10 ml per kilogram per hour for 1 hour, and there was no improvement in the pulse pressure, in the heart rate, patient continue to be tachycardic, then you get your hematocrit. Okay. Now, if the hematocrit is increased compared to the last hematocrit that you have at the expense of this compensated shock, then you challenge again with the second bolus of your crystalloid, this time giving the patient 10 to 20 ml per kilogram per hour for an hour. Okay. So if there is improvement of the blood pressure, the pulse pressure, and the tachycardia, then you reduce your IV crystalloid to 7 to 10 ml per kilogram per hour for 1 to 2 hours. And then follow this one until you'll have 2 to 3 ml per kilogram per hour at the expense of a clinical improvement, and hemodynamics are also stable. Now, in the event that your patient did not improve and the hematocrit was lower compared to the baseline, then there are two possibilities. Okay, your patient may have severe overt bleeding. Now, if there is severe overt bleeding, you have to identify where's the bleeding. Okay, and urgent blood transfusion is necessary aside from challenging the patient with crystalloid, because if you do further boluses with your crystalloid at the expense of a decreased hematocrit, you might also develop pulmonary edema. And this is where most of our clinicians are unable to predict, because they thought that it's purely just transfusing platelet and not transfusing volume. If in the event that the hematocrit is decreased and you see that you have ruled out severe overt bleeding, then instead of blood transfusion, you can administer your colloid. Okay, so your colloid can be given at 10 to 20 ml per kilogram per hour. So which means that there's some element here of a plasma leakage, and not necessarily bleeding, but just a mild bleeding, and also consider blood transfusion if in the event that your colloid will not expand, will not normalize the blood pressure and the narrow pulse pressure, then you can do blood transfusion. And if there's no clinical improvement, then you have to refer to an expert consultation in order for you to address subsequent management. No? So some important things to consider here is that adequate and appropriate fluid resuscitation to the extent of not causing fluid overload. No? So in fact, a maximum of 3 liters per day may be enough in some of these patients with an average weight of 50 to 60 kilograms. But again, it will depend on how you will assist this patient in terms of to prevent fluid overload. Now, assess for the presence of occult or overt bleeding if still unstable, and monitor the hematocrit. Remember, the most common cause of bleeding during this time is always the gastrointestinal tract, no? So intra-abdominal bleeding. Now, the fourth case scenario that I would like to share with you is the patient has been admitted, and despite fluid resuscitation, the patient was unable to urinate for 8 hours and later developed hypotension. You hydrate because you want to correct the BP, but the BP returned to normal. But again, the patient still anuric. And then after that, the patient had pulmonary congestion and the patient died. So what happened to this particular patient? So this is a case that is really complicated, no? And we have seen some of these cases in our hospital. And this is a result of two aspects of your fluid overload. So one aspect of your fluid complication of your fluid overload is that during the time that the patient is already in the recovery stage, where you still continue to give large volume of fluid and you overload the patient, and at times it might be the cause of the demise of the patient. Or the other part here is that during the critical or the early convalescent phase of the infection, where you also push a lot of fluid because the patient presents with shock or signs of fluid overload, what are you going to do? Now, this is the time that when you have a patient with signs of fluid overload, and at the same time, your patient is still hypotensive, especially during the critical phase of the illness, you should not be pushing a lot of fluid because remember, your crystalloid will just be concentrating in the extracellular compartment and it will easily cause pulmonary edema. What you want to do here is you want to normalize the blood pressure by maintaining a very good intravascular volume. And what intervention for you to maintain that intravascular volume is giving a patient your dextran or your colloid at a rate of 40, or your dextran at a rate of 10 ml per kilogram per hour or 500 ml per hour. And at the same time, while you are infusing your dextran, you can also give your furosemide, okay, in order for you to open up your kidney while maintaining an intravascular volume. Now, in the event that when you get the hematocrit, that the hematocrit decrease less than 10 points, that means that you are adequately, you have adequately expanded the intravascular volume, and at the same time, not necessarily lower risk already of your fluid overload. But if the hematocrit further decrease of more than 10, so there is really hemodilution. So you are putting a lot of fluid and it's not expanding the intravascular volume, then you need to transfuse your PAC RBC. Because at this time, there's a possibility that the shock at this point in time may be due to a bleeding complication and not necessarily because of a plasma leakage. And this is where you can correct your intravascular volume with the use of your blood transfusion because your colloid or your dextran may not be enough to maintain that particular intravascular volume. But if in the event that the patient did not improve and still with no urine output, then the patient still with dyspnea, as what happened to this patient, or tachypnea, then most likely you have already a renal dysfunction as a result of the previous inadequacy to perfuse the kidney. And in this particular patient, it's important that you have to refer this to a higher center and mainly for dialysis, okay? And look at also some aspect of ongoing third phase leakage in the form of pleural or peritoneal fluid accumulation so that you'll have to do evacuation of that fluid in that particular area. And then check also the ABCS in the resuscitation of your patient and consider giving mechanical ventilation. No? So you have a full support of your lungs, your GI tract fluid leakage, and at the same time, because of renal dysfunction as a result of persistent hypotension, then you have to do dialysis. So I would like to share with you here in this particular group of factors that the most common causes of fluid overload include the use of insistent or persistent hypotonic solution hydration, too much drinking of plain water. There is already kidney renal perfusion deficiency due to the critical phase wherein you're not able to correct the perfusion. You're not able to hydrate the patient to maintain that adequate volume and perfuse the kidney. And there's also failure to decrease or discontinue the IV fluids after the critical phase when your patient had fluid overload and contributing to the decrease in the cardiac output, and at the same time decrease fluid, decrease perfusion to the kidney. Failure to monitor the urine output, and that's why because of that persistent anuria, that's already a sign of poor renal perfusion. Number 7, inappropriate use of large volume of IV fluid in patients with unrecognized severe bleeding. Remember, when you have severe bleeding, transfusion replacement is important rather than just putting a lot of fluid to prevent pulmonary edema. And then inappropriate transfusion of fresh frozen plasma and platelet concentrates. A lot of clinicians prefer to do or give a lot of platelet concentrate because of thrombocytopenia. Remember, thrombocytopenia is always part of the clinical manifestation, and it's not the one that's causing the death of the patient. It's always the plasma leakage, and as a consequence of some bleeding disorder, not necessarily secondary to thrombocytopenia. And then also there are patients that are higher risk to have fluid overload, especially for those with heart problem, like heart failure, or those with chronic lung and renal diseases, when the margin of error there in terms of fluid resuscitation should be closely monitored to prevent also pulmonary edema. Now, in this particular patient, we go back. This patient was unable to urinate for 8 hours and later developed hypotension. You hydrated the patient, the BP returned to normal, but still the patient's output, urine output was 0, and later died because of congestion as a result of fluid resuscitation at the expense of poor urine output. No? So this patient's pulmonary congestion is brought about by renal dysfunction. So the patient developed intravascular hypovolemia due to the plasma leakage. Hydration was done later. And again, in this patient, the blood pressure returned to normal. But because of the kidney injury brought about by the hypotension earlier as a result of failure to resuscitate the patient can no longer urinate well. And thus, this later developed to congestion, which subsequently was the cause of the mortality of this patient. And this is why urine output monitoring every hour is very important, from the time the patient is admitted to the time that you have the critical phase, because that is your window of indication that you are perfusing the patient, adequately hydrating the patient. Because a patient will develop hypotension, then that's already a sign that your kidneys can also be damaged. So you should not take that into consideration. You have to correct your blood pressure, because not only you will be able to preserve the kidney function, it will also prevent the fluid overload. Now, would like to share with you the importance of colloid use in dengue, no? And that is why that when you will be resuscitating your patient, you should be conscious enough that there is only a certain point that your IV fluid will work in terms of expanding the intravascular volume. And if that will not work, then you need to decide when it is to appropriate to give your colloid in dengue. So this is usually indicated in dengue when there is already signs of compensated shock or hypotensive shock not corrected by a crystalloid fluid, or when there is also signs of fluid overload, because putting more crystalloid fluid will only go to the extracellular compartment and causing and aggravating your fluid overload or pulmonary edema. So currently, the colloid that is recommended is 10% dextran 40 in NSS, or the presence of your 6% heta starch or your Voluven, which is, I think, what is available in most government hospitals. So what is the dose here? It's 500 ml per hour at a time, and monitor the signs of appropriate or adequate intravascular volume resuscitation. We also need to look at some important complications of prolonged shock, no? Because the longer the patient is hypotensive, then the higher that you'll have other organs affected. Okay, that will lead to multiple organ failure, and that's why you have what we call the expanded dengue syndrome. So early recognition and management of severe dengue to avoid prolonged shock. You educate the patient, even at the outpatients, regarding the warning signs. Instruct them to closely follow up with you. You do daily follow up with your CBC, especially for those suspected dengue, and investigate for evidence of plasma leakage by using your ultrasound. You can do ultrasound of the lungs or of the abdomen to look for pleural effusion or fluid in the abdomen, or more or less, if you have an albumin level, that will also be a higher risk of pulmonary edema when your albumin level is also low. Now, recognition and management of complications and less common dengue syndrome. Always consider and treat bacterial infections, bleeding, or even severe hepatitis as a result of the infection. So we always emphasize the importance of blood transfusion in dengue. And here, this is where we need to reserve two types of blood, your fresh packed red cells or your fresh whole blood, especially for those patients with high risk for bleeding, and then monitor them. Now, fresh frozen plasma, platelet concentrate, or cryoprecipitate are indicated only in confirmed DIC. So, meaning these are not the usual blood transfusion that we should be giving to our patients. No? So, this is only the case that they have disseminated intravascular coagulation. So, what are the indications of this blood transfusion in patients with severe dengue? So, you only give this in patients with severe bleeding, especially for those who will present with melena, hematopesia, signs of shock. Refractory metabolic acidosis is also a sign that there is an ongoing severe bleeding, intra-abdominal bleeding, or if the patient will present with progressive distension of the abdomen. Remember, prophylactic platelet transfusion for severe thrombocytopenia in an otherwise hemodynamically stable patients are not necessary. And still, we encounter a lot of this in some of the hospitals that I'm an active consultant, where when they look at patients with dengue, they focus on the platelet count, and when they see that the platelet count is increased or decreasing, it's a knee-jerk reaction among some of these clinicians to just transfuse platelets. So remember, platelet transfusion is not the most important intervention. It's really expanding their intravascular volume. And if they are hemodynamically stable, more so that you don't need to give them platelet platelet transfusion, because the main problem there is anticipating the possibility of plasma leakage. So I would like to show here that there are patients that are high risk of severe bleeding, especially for those who present with refractory shock, those who are hypotensive and remain or have multi-organ failure. These are patients that will really go into severe bleeding. Those with severe and persistent metabolic acidosis, those given non-steroidal anti-inflammatory agents prior to admission because of fever. Remember, they can also aggravate bleeding because of decreased platelet function. The presence of pre-existing peptic ulcer disease. We see a lot of these patients with history of PUD. When they will be admitted, they also manifest with intra-abdominal bleeding. Those on anticoagulant therapy, and any form of trauma, including intramuscular injection. So when you have any of these patients, then it's important that you need to reserve blood, for possible transfusion if you have this type of patient. So if I'm going to say that enumerate factors that will lead to severe dengue, it just cannot be explained by one important risk factor. It's contribution of different factors ranging from epidemiological factors, individual factors, including viral factors, especially the strain of the virulence of that particular dengue virus, which can also be a determinant of more severe form of dengue. For the individual factors, you always need to look at host response and the presence also of a secondary dengue infection. Okay, so these are some of the indications for referral to a higher level of care that we included in the 2019 updated dengue clinical management guideline. I hope this will help you in terms of identifying these patients, that they should also be referred to a higher level of care. And that is why in most primary healthcare facilities, there should be a partner tertiary level of care, so that in any event that this patient will have any of these manifestations, they can be admitted to these care centers. No? And consider also what we call the ABCS, when there is no improvement in spite of adequate fluid therapy. So what are these? No, you need to correct the metabolic acidosis early. You have to suspect that even at that instance where you adequately did fluid resuscitation, there is still hypotension. There could be the presence of concealed bleeding. You detect hypocalcemia, the presence of hypoglycemia, including hyponatremia. So what are the key messages that I would like to share here is that the key to the management of dengue is always reducing mortality and morbidity. And one very important role of the clinician is always to recognize the disease phase the patient is experiencing at presentation or is transitioning, implement judicious and controlled manner the required interventions to comfort and address key pathophysiologic mechanisms, mainly plasma leakage and bleeding. And then it's also essential that patients, the parents or guardians of patients, and clinicians are cognizant of the warning signs and symptoms for plasma leakage and intravascular volume depletion. So you need to educate the parents, the guardians, including those who, especially for those who have higher risk of dengue, that there are warning signs, that with that warning signs, they have to be closely monitored, and in fact, they have to be admitted to the hospital for close monitoring. Other important messages here is clinicians must also follow the clinical and biochemical clues of volume status to avoid contributing to volume overload, wherein one of the important findings of the WHO that increased mortality was also in relation to the fluid overload. The presence of comorbidities, you have to identify who are these patients having these comorbidities, because the presence of these comorbidities is also related and correlated with severe disease and poor outcomes. And more importantly, we always need to base our management on evidence-based clinical algorithms that is currently being recommended, and which are also highly effective in terms of preventing death and preventing mortality. Okay, so I would just like to share with you that in this updated guideline by the Department of Health, this entails empowerment not only by the clinicians, but also lowering the empowerment at the level of the primary care to identify patients with dengue, to identify patients that are higher risk of severe dengue, and at the same time institute the appropriate therapeutic management in order to prevent them from going to the different complications of dengue, particularly plasma leakage and bleeding. With that, thank you very much for your kind attention, and I'm ready to entertain questions or reactions for this particular topic. Thank you.
Thank you very much. That's Dr. Jean Solante of San Lazaro Hospital. My goodness, we haven't had this kind of comprehensive lecture in such a long time. You'll see the appreciation of
That's true.
the audience.
It's a master class, Dr. Susie.
Master class talaga ito, Raymond. It's like we have to require this for all medical and nursing students, no, to watch this. So, Jean, thank you so much for all the preparations you put into this. You'll see in the chat that many people are asking for your presentation, and definitely I encourage everyone to watch again. Okay, so go to the playback and watch again because it was really excellent, an excellent presentation. Thank you so much, Jean. So we've got another speaker. So Raymond, over to you and your classmate.
Thank you, Dr. Susie, and thank you so much, Dr. Solante. I know there are a lot of questions that are burning sa ating audience, and hopefully those questions could be asked during the Q&A session. Just to remind everyone, for today's Q&A, we will choose from the upvoted questions. We encourage everyone to start typing in your questions in the Zoom Q&A or in the comment section if you are watching in the YouTube channel or in the Facebook pages of Stop COVID Deaths and TVU people. Now, it's my pleasure to introduce to you our next speaker. He's been with us for a long time and has served na po multiple roles, even as co-host dito po sa ating Stop COVID Deaths webinar series. He is now Director 3 of the Health Finance Policy Sector of PhilHealth, the Philippine Health Insurance Corporation. Please welcome again to your screens my classmate po, Dr. Albert Domingo.
Hi, good afternoon. Nice to see you again, Raymond, my classmate, and of course, Doc Sushi. Magandang hapon po sa kanilang lahat. Thank you so much for the kind introduction. Do we go straight to the
Yes,
slides?
TVUP, may we have Dr. Albert? There we go.
Perfect. Here we go. Mabilis lang to, Dr. Raymond and Doc Susie, no? So, this is now the question. Can you atras muna naman, please? Huwag muna kagad dun sa second. So, the question now that we'd like to answer, or my reaction on behalf of the Philippine Health Insurance Corporation. First, marami pong salamat sa ating TVUP, of course, the University of the Philippines as a whole family for continuing to do the Stop COVID Deaths webinar 135 na. And the reaction is about how PhilHealth pays for dengue. Yeah, next slide, please. When we say how does PhilHealth pay, we are actually talking about a concept in health financing called strategic purchasing. Two words, strategy and purchasing. Ibig sabihin, madiskarte dapat yung pagbili. Yung mga bagay na binibili ng PhilHealth, and when I say PhilHealth, because the concept is everyone pulls together their funds through premiums. Nagbabayad po tayo ng mga premium contributions sa PhilHealth. Para sa mga hindi nakakabayad, binabayaran sila on behalf of the government. Yung po tinatawag na indirect contributors. PhilHealth now makes strategic decisions to pay for health goods and services na kinakailangan. Yung talaga bang sigurado tayo na pag binili mo yan, di kalidad yan, at yan ay magre-resulta dun sa mga sinasabi na nakakagaling. I was listening to the lecture of Dr. Solante, and indeed, no, parang masterclass nga. Medyo pinagpawisan ako ng konti kasi feeling ko mag-i-endorse ako sa Guasunol after a few. But the key message that I parang stuck with me is dapat hindi masyadong mabilis mag-hydrate, and we have to monitor urine output, and we have to make sure that we are not overcompensating. Kasi nga naman, parang kahit sa mga doktor na ako as a general practitioner, hindi na nga ako nagpa-practice, iisipin mo, lagyan mo yan ng swero, tapos lagyan mo yan ng intravenous fluid, okay na. It's not that simple, apparently, no? Next slide, please. Of course, let's review the overall campaign of DOH. Yung tinatawag na 4S, di ba? Search and destroy, that's environmental health and health promotion. Self-protection, yes, that's also health promotion. Skip ko muna yung third kasi obviously dun yung pag-uusapan natin. Yung fourth one is yung support fogging. That's also probably outbreak measures na pag may emergency. Let's zoom in on S number 3. Yan, si S3. Yung seek early consultation. We all heard Dr. Solante say that the earlier we figure out, the earlier we find out that a patient has dengue, then the better we can intervene. I just have to say that actually I'm right now here on the sidelines of the National Cancer Summit. It's the same message sa cancers at sa dengue. The earlier we are able to detect the patient or the disease rather, then the faster we can intervene and the better the health outcomes. And this includes the individual-based services under primary care, secondary care, and tertiary care. We are all familiar with tertiary care and secondary care. Most of what Dr. Solante discussed is within the domain of tertiary care. I would imagine nasa kung hindi man nasa ICU, nasa intensive care unit or critical care, at the very least nasa ward, baka siguro sa secondary care. But did you know, and we will find out later, there are also para bang patients being managed under primary care. And that brings to mind rather the question of quality. No? I'm not saying hindi magandang management, but what I'm saying is we need to make sure that the services are of high quality at all levels. Next slide, please. So that brings me to now, I will not dwell on this. I just wanted to show you that these are examples further to what Dr. Gina presented, no? Yung mga standards for the clinical management of dengue. Bakit kailangan i-highlight yung mga standards? Kasi para maging strategic purchaser si PhilHealth, para alam ni PhilHealth kung ano yung bibilhin, dapat meron siyang grocery list. Dapat meron siyang listahan ng pamamalengke na what do we buy? And that is what the clinical practice guidelines, or the standards as we call them, that is what PhilHealth relies on. So actually, in the normal process of things, there is a unit within PhilHealth, the Standards and Monitoring Division, that works together with the broader health, finance, and policy sector and the Quality Assurance Group to make sure that what the benefit packages, meron nga pala tayong benefit BDRD, Benefit Design and Research Department, sila yung parang all together, they make sure that these standards, the things that Dr. Solante discussed, that we should avoid overhydration, we should be very careful when you do that, these should be adhered to and these should be supported by the financing that PhilHealth provides. Next slide, please. And having said that, it is important for us to know the context of the big picture. We zoom out. I know rather that the discussion here is parang focused on the individual patient, but PhilHealth operates at the level of systems. And we are seeing here a very parang simplified summary of what you call the healthcare provider network, with the apex hospital at the top, with secondary care and tertiary care dun sa middle portion, and primary care sa baba. On the right side of the slide, there are different financing instruments that PhilHealth uses. Bakit merong now, tsaka merong coming soon? Because we are in a transition phase. Following the requirements of the Universal Healthcare Act, PhilHealth is shifting towards what you call the diagnosis-related groups global budget. What is the importance of that, Doc Albert? We are talking here about the fluid management and the proper management of dengue. Well, because when the diagnosis is made under the current scheme, alam to ng mga doktor, no, tsaka mga hospital administrators, 2 case rate lang ang pwedeng isulat. Lagyan na natin yung case rate ng dengue, tapos siguro may isa pang procedure. Paano kung may ginawa pang iba? Paano kung may iba pang sakit or something na kailangang i-manage yung pasyente? At present, ang nangyayari, maximum 2 case rates and that's it. Kaya yung support value, yung kino-cover ng PhilHealth, hindi ganon kataas. Under the DRG, we are not promising na tataas dramatically, but at least the DRG recognizes many diagnoses, medical diagnoses, and also surgical procedures that when bundled together forms what you call a diagnosis-related group. Eh ano pa rin connection nito, Doc Albert, din sa pinag-usapan natin na fluid management? The question now is, are we going to pay for the colloids? Tama ba yung naalala ko, Dextran, yung sinabi ni, maybe the hospitals have it, especially the public hospitals, or if they don't, the question is, does the PhilHealth case rate at present, or will the PhilHealth DRG in the future include the cost items of these things that Dr. Solante and the guidelines are referring to? But on this same slide we are talking about, look at the bottom dun sa right, yung consulta tapos may cross. Yung consulta plus, dyan tayo mag-zoom in. Yan yung primary care. Yan yung early detection na sinasabi. Next slide, please. Sinasabi ni Dr. Solante at ng guidelines, we need to catch the patient early. And ang ganda yung sinabi niya kasi ako, guilty ako dun na parang inaantay mo magkaroon ng rash. Rashes are not pathognomonic apparently, no? Parang marami kang mga dengue na walang rashes, no? So ano yung mga signs and symptoms? Yan yung mga things na kailangan kabisado, kailangan pinagpa-practicean, kailangan alam na alam ng ating primary care providers. And where does PhilHealth come in? Well, we have to make sure that we are paying for the services of these primary care providers through the consulta package. Right now, if you are in a live audience, as I did earlier dun sa mga cancer stakeholders, tatanungin ko, ilan dito ang may alam na meron palang consulta package for primary care ang PhilHealth? Tataas ng kamay ganyan. Tapos tatanungin ko ulit, doon sa mga nagtaas ng kamay na yung konsulta, ilan sa inyo ang registered? Tapos bababa yung mga kamay. Tapos sa mga naka-register, ilan sa inyo ang nakagamit na? Pakunti ng pakunti yung kamay. That is the challenge for us in PhilHealth. Why? Because the consulta package, as you can see on your screen, includes CBC with platelet count, among other things. It also includes medications like paracetamol and oral dehydration. And it pays for the time of the physician or even the primary care provider as part of the team, like nurse or any other healthcare provider that can catch dengue easily at its early stages given the right training and listening to lectures like that of Dr. Solante. Word of word from our sponsors. Next slide, please. Now, meron tayong konsulta, pero importante, ito, bibilisan ko lang to, no? Kasi this one is really for the providers, pero kailangan makita po ninyo. If you are a consulta registered provider and there is an accreditation process, you may be able to claim per capita. Kung ilang pasyente yung nakaregister sa'yo, multiplied by a maximum amount. Bakit maximum? Kasi merong performance indicators that will vary the amount that you will receive. This is the rate. So imagine, if you are able to register 1,000 patients, then you multiply 1,000 times 500 kung ikaw ay nasa RHU. So ano bang math yun? Medyo nahirapan ako. O di 500,000. Oo nga naman, 1,000. For that particular set of patients. And this is what PhilHealth pays you, assuming you comply or you perform the targets, you deliver the targets, the performance targets requested. Yung number of individuals consulted, number of laboratory services done, and the medications prescribed. Imagine kung ikaw ay nagpa-CBC serial, hindi ko alam kung yun pa na yung standard, no? Pero just assuming na kailangan siyang i-CBC at primary care level, ma-mark mo na yun as one of your performance targets. The fact that the patient consulted to you, kahit hindi ka nag-CBC at ikaw ay nagbigay ng, tinignan mo siya, in-examine mo siya for the signs and symptoms of dengue, or nagbigay ka ng advice, or nag-refer ka, counted na rin yun. That matters when it comes to the payments for PhilHealth Consulta. Next slide, please. Paano naman sa hospital? Yan yung mga inpatient benefits. Next slide, please. It is important for the inpatient benefits to be as closely costed as possible. These are the current case rates for dengue, A97, 97.1, and 97.2. The first two from the top, si 97 at si 97.1, pwede siyang sigurong i-manage sa primary care. Ito yung sinasabi ko kanina. Pero the reimbursement is only 70% of what the rate is. So hindi siya 10,000, 7,000 siya. If you are a level 1 licensed, let me correct myself. I think infirmary. If you are an infirmary within the DOH licensing scheme. But take note na yan yung sa DOH licensing. PhilHealth at present yung konsulta, kahit hindi ka dun sa level 1, kahit ikaw ay basta mamimit mo yung standards na required ng PhilHealth, then you can actually still be an accredited consulta provider. Now look at the 16,000, yung A97.2, yung severe dengue. That has an asterisk, and I put there, will be rationalized. This year, PhilHealth is looking at the costing of the severe dengue package, or A97.2, the case rate for severe dengue, in recognition of updated parabang guidelines or guidance, like what we just heard from Dr. Solante, just to make sure that we are paying for the right things and at the right amount. Next slide, please. Having said all of that, so meron tayong primary care package, meron tayong secondary and tertiary care package, we need to ask ourselves, lahat tayo, mapa kami sa PhilHealth, mapa tayong lahat po as members, kasi members din po kami. At mga healthcare providers, how do we make sure that strategic purchasing will lead to seeking of early consultation, meaning will lead to patients going to their doctors or their healthcare providers for early consultation, and for the doctors and the healthcare providers to be there to begin with, supply and demand meeting together. Let's ask ourselves, ano ba natin yung konsulta? Registered ba tayo? Kung tayo ba ay registered sa konsulta, ginagamit ba natin? Are we aware of the inpatient case rates for dengue? And yung bang doktor natin sumusunod sa CPG? Of course, hindi naman tayo pagtatanong, Doc, sumusunod ka ba sa CPG for dengue? Nag-attend ka ba ng UP webinar ni Dr. Solante? At narinig mo ba yung sinabi? Hindi tayo doon magtanong. But there is a way. A lot of hospitals now are very proud when they say we adhere to quality standards. And they will say, we adhere to the latest guidelines by the DOH and by the specialty societies. Yun yung isang signal na dekalidad yung ospital. Now, on the part of healthcare providers, we asked, are we accredited under PhilHealth Consulta? To begin with, are we accredited for PhilHealth para tayo ay pwedeng mag-bill dun sa mga case rates and later on dun sa DRG na sinasabi? And sa mga hospital po, how much do we cost for dengue admissions? Is the basis of our costing the latest CPG, yung latest guidelines? And for all of us, whether members or healthcare providers, do we participate in CPG formulation and adoption? And in closing, kung kami po sa PhilHealth ay tatanungin ng sarili namin, ito yung mga dapat na, kumbaga, examination of conscience. Yung mga questions that we have, we do ask ourselves these questions when we have our technical meetings and even all the way up to the board. How close to the market rates are the outpatient, capitation, and inpatient rates? Talaga bang kaya nating i-cover? But ladies and gentlemen and everyone, the difficulty here is, ito yung medyo, hindi naman sensitive, pero sabihin na nating mahirap talaga sabihin, but it's the reality. If PhilHealth is not given adequate revenue by way of either premium contributions or subsidies from government, mahihirapan tayo to increase the benefits because the actuary has to balance the resources available with the payouts. We want more payouts, we want more benefits, but this has to be paid for. Yan yung balancing act lagi. And the key here is the correct estimations based on the CPGs and the other guidelines that we know. And of course, yung last bullet point, pinaka-importante, how can collection and payment be made more efficient? Now that the President has instructed and PhilHealth is complying that we are suspending, we are not increasing premium contribution rates this year, the challenge for us is to make sure that collection efficiency is higher. Kasi kahit meron tayong rate na alam, kung hindi naman lahat tayo nagbabayad, hindi nagko-collecta, etc., then hindi natin mababayaran. At yung sinasabing payments, dapat hindi rin mabagal, dapat mabilis, on time, as fast as possible ang reimbursements sa ating mga providers. I think that's the last slide. Next slide. At maraming salamat po again, and over back to Doc Susie and Doc Raymond.
Thank you very much, Albert. Another very good presentation. It makes me think, maybe we should really be having PhilHealth input, Raymond, no? Parang after we have these discussions on guidelines, we have some PhilHealth inputs. Okay, we have one more speaker. Who is so thank you, Albert. Please stay for the Q&A. And we have Ludina Insigne, who is the coordinator for dengue in Region 8. And as you know, in the news, there's been reports of an outbreak in dengue. So let's hear from her very briefly what is going on there. So let's go to Dr. Insigne. Is she here, Raymond?
Yes, she's here. She's here. TVUP, may we have the slides of Dr. Ludina on the screen? Thank you.
Hi, good afternoon.
Good afternoon, Doctora. We're just pulling up your slides. There we go. Okay. Go ahead, ma'am.
Thank you for this opportunity po to present the National Aedes-borne Viral Disease Program of Eastern Visayas. With me is Sir Leonido Olobria. Next slide, please. So these are the dengue cases in Eastern Visayas from 2018 to 2022. As you can see, we had an outbreak last 2019 with a total case of 26,623. And during the start of the pandemic, there was no cases of dengue noted. Baka siguro because the health workers were focused on the COVID response. And earlier of 2021, there was a decline of number of dengue cases, and also in 2022. Next slide, please. So this is the dengue mortality in Eastern Visayas from 2018 to 2022. As you can see, during the outbreak, the year of 2019, we had a total deaths of 75. But the case fatality rate of the region was less than 1%. That means that early interventions has been done, and also medical interventions was conducted. Next slide, please. So actually, for the morbidity rate of dengue in Eastern Visayas per 100,000 population, we actually targeted to decrease 25% of our cases. So during 2019 and 2018 and 2019, we're not able to achieve the target. Okay, as you can see, we have high cases. It's beyond our regional target. But then the year 2020 and 2021 and up to 2022, we were able to reach our target, the decreasing the cases by 25%. So this is the distribution of dengue cases by morbidity week. So this is from morbidity week 1 up to 7 of the current year. So our cases started at the morbidity week 1 and peaked at morbidity week 2. As you can see, we have decreasing number of cases. So this is based on the date of onset of cases. So for the cases and deaths, so from morbidity week 1 to 7 of the current year, 2023, we have a total cases of 549 with 2 deaths. And with a case fatality of 0.37, and the age range is from 2 months up to 83 years old with a median of 11, and with a predominance of males. Among these cases, 512 were admitted, about 93%, and about 42% were confirmed based on the case classification, and with 47% suspect. So these are the distribution of fatalities by province. As you can see, we have 2 deaths from Tanawan and San Miguel Leyte. So what are the strategies implemented? So we have a central policy on the guidelines for the nationwide implementation of the enhanced 4S. So we really encourage the LGUs to follow and abide with these strategies to really decrease their cases. Next slide, please. And also, we have an advisory on dengue preparedness and outbreak response, and also use of dengue epidemic preparedness and response checklist to address the increasing number of reported dengue morbidities. And also, there was a DM 2019-0316 on the implementation of Sabayang 4 o'clock habit para dengue get out. And also strengthening of the 4S enhanced strategies and the reiteration of the need to strengthen the enhanced 4S strategies. And also guidance in anticipation of possible increase in cases of infections during rainy season amidst COVID-19, and the guidance in anticipation of possible increase in cases of dengue cases during the rainy season amidst COVID-19. So also we crafted local policy at the regional level on protecting people from dengue infection. So we release advisories to LGUs for them to follow, aside from the policies that were coming from the central office. Also a advisory in the national simultaneous search and destroy and clean up drive. So just recently po, we crafted a local policy on early intervention for dengue prevention and control. So we observed that earlier that we released advisory to really remind our LGUs for early detection and also early management of our dengue cases. And also local policy on dissemination and policy adoption or implementation of our DILG memorandum dated March of 2022. So we observed that some of the LGUs actually they are not they're not aggressive on combating dengue. So we top the DILG para at least mas may backbone and really to follow the policies that the central office and the regional office have been handed down to them. So also a policy requested for the DILG on the reiteration of the cleanup monthly cleanup drive Actually, kasi pag hindi natin ini-remind ang ating mga LGUs as to the cleanup drive and wala ding ngipin from the DILG, so hindi sila sumusunod. So for the regional office, we really coordinated with the DILG for the implementation of the monthly cleanup drive. So for the trainings conducted from 2018 to 2022, we were focused on training on dengue clinical management, and also last 2021, a training on integrated vector management. So for the dengue mortality review, we conducted last year dengue mortality review. The total deaths reviewed from 2020, 2022 were 12, and 2021 5. So from the dengue mortality review that were conducted last year, we were able to get these findings in the dengue clinical case management training and dengue mortality review. So out of 11 out of 17 health facilities or RHUs and hospital have dengue rapid diagnostic test, but with limited numbers. And about 12% or 71% out of 18 are performing the CBC and platelet examinations. And about 5% or 45%, 5 or 45% out of 11 hospitals were represented during the mortality review have available plasma expanders in their facility. Okay, and about 2% or 50% out of 4 hospitals were reported have a problem with incomplete history taking. So as we all know that about 80% of diagnoses are made by comprehensive history taking and physical examination. Next slide, please. So for the advocacy activities, we conduct dengue awareness day celebration and also dengue radio plugging in 6 provinces of Region 8. And also we reproduce dengue IEC materials for every municipalities in the region, and also created audio or video presentations in the conduct of dengue vector surveillance, and also provide dengue audio video presentations to be shown in every health facilities. So as one form of our advocacy is really to give them the IEC materials and also these video presentations that would really help them, especially in terms of advocating their LGUs. And also for the logistics support, we procured and distributed the following dengue commodities in the 6 provinces, and including the insecticides for fogging and misting, and also insecticides for larviciding and pupaciding, and also dengue dual antigen antibody rapid diagnostic test. So we have issues and concerns. Number 1 is the vector control, or for the prevention side. There is a low coverage for search and destroy activities. The people are very dependent on fogging, resulted also to complacency of for the community participation, and also low appreciation for larval survey data utilization. So they conduct larval survey pero hindi nila ina-analyze, so wala din gamit for the LGU kung hindi nila i-analyze. And also a lack of personnel to do the fogging operations. Like I've said, yung ating mga foggers are trained, dapat i-train sila. So hindi lang kung sino-sino yung magfa-fogging. And also case management. So there's overcrowding of dengue patients in hospitals and health workers fatigue. And also unavailability of your CBC and platelet examinations in some RHUs and other health facilities. And also there's lack of plasma expander and blood products in the hospital. So actually during the dengue mortality review, we identified na kaya hindi rin na manage yung namatay yung case because there was a late referral and walang available na plasma expanders and walang available na blood in the hospitals. And also for the logistic management, pwede po ba pabalik? There is a rapidly depleting RDT supplies and insecticides for fogging and misting and insect repellents. Actually, the LGUs are very dependent on the allocation from the regional office. So when in times na madaming ating cases, we really encourage the LGUs to procure at their level para at least kung wala si HD or wala si central office, mayroon silang magagamit po. And also, inadequate program funds, the program is very dependent on the sub-allotment from the central office for procurement of vector control commodities or insecticides, and also the RDTs for outbreak response. So minsan pag may mga outbreak kami, nahihirapan kami especially for the procurement of RDTs kasi yung aming naka-buffer stock namin is nagagamit na din for the LGUs. And also, difficulty to settle dengue mortality reports, where attending physicians do not attend mortality reviews, and consultants of dengue mortality review discover that deaths reported are not due to dengue. So, example, out of the 20 deaths, 5 ay hindi dengue related. Kaya nga, with the program, we are very vigilant in terms of deaths namin. So, we really encourage at the hospital level, especially yung ating mga RHU or hospital or district hospitals to really conduct their own to have their own dengue mortality review committee. Para at least when they will present it to the regional level, mas konti na. So na-validate na nila lahat. Ito ay hindi death secondary to dengue or may ibang comorbidities. That ends my report. Thank you.
Okay, thank you very much. That was Dr. Ludina Insinin. So thank you so much for joining us on the webinar and giving us that update. Okay, I'm not sure if Jean Solante is with us already, Raymond.
I still don't see him, but Dr. Susie. So
yeah, we have time for 2 questions. If Jean is around, is Jean there?
Are you here, Dr. Jean? I don't see
Jean,
him.
nandiyan ka ba? Okay, do we have any questions on the insurance side, Raymond?
Well, on the insurance side, I think it's more about accessing certain drugs, and will those be covered? That's more.
Yeah, let's ask Albert. Let's ask Albert to answer that question. Then we'll go to the fun quiz and evaluation because we're closing at the top of the hour already. Go ahead.
Yes, correct.
Raymond.
Yes, for the questions in relation to Telehealth and reimbursements, what is the extent daw po that will be covered for dengue cases now, and specifically when we go to DRGs, will there be, I know Albert has already mentioned there might not necessarily be a significant bump in terms of the coverage, but what can be expected when we shift to a DRG-based assessment po?
Thanks, Raymond. So right now, direct answer to the question, the package rate, the case rate for dengue without warning signs, A97.0 ICD-10 is 10,000 pesos. The dengue with warning signs, A97.1 is also 10,000. But if you are at primary care, that becomes 7,000 pesos for both. And then for severe dengue, A97.2, it's 16,000. As to the question on what it will be later on sa DRG, DRG is a complicated thing, but just to give a soundbite, we have to make sure that the diagnosis of dengue is packaged together with what we expect happens to a dengue patient. Yung sinasabi ni Doc Jean na pulmonary edema, o ibang diagnosis din. Pero if it all happens in the same patient, that is bundled together. And what's important is what you call the relative weight, the RW, is computed properly. Imagine lahat ng ospital, tatanungin sila, magkano bang ginagastos nyo pagka ganito nangyayari sa pasyente? Tapos kinukuha yung average, tapos nag-assign ng relative weight. I am simplifying, and I hope at some time in the future, maybe we can discuss what DRGs are all about. Back to you.
Thank you. I think let's do that one day, Albert. No, I think there's an interest in it. But, due to the lack of time, we're going to give both the two panelists we have here a minute or two to think about a final message. And then, Raymond, let's just answer the fun quiz.
Yes. Can we have the fun quiz on the... There we go. Can we have it on Slido also on the screen? So the questions that we have are threefold. Questions came in from Dr. Solante. Number 1, how to confirm dengue. So multiple ways here. If I remember correctly, I think it's all of the above when we were going through the list, specifically for question number 1. For question number 2, the warning signs of severe dengue. All of the above. So pagdurugo po ng gilagid, pagsakit po ng ulo, tsaka mananakit ng tiyan, all of those are warning signs of severe dengue. And then number 3, it's the third question, how to prevent mild dengue from progressing to severe. So marami po ito. You'll have to be able to test yourself and immediately identify the warning signs, but also be sure that you are able to do an immediate decision if the patient needs to be admitted. So bottom line, it's all of the above din po for question number 3. So as our speakers po are trying to come up with their final messages to our audience, may we have on the screen the evaluation poll? Sige po. So our evaluation poll, there are 5 questions and this is a 4-point Likert scale. Something that we've also, we've asked thoroughly in previous webinars, but really there's no separate evaluation poll that we sent out. Ito na po iyon. So hopefully all of those that are in the Zoom will be able to participate. Hopefully you're able to see. There we go. I'm seeing answers coming in now. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, panelists contributed to new perspectives and knowledge on managing various key health issues. Remember, we will not be closing this evaluation poll as we move on to the final messages of our speakers. Dr. Susie.
Yeah, thank you. So brief message from Dr. Ludina all the way from Region 8. Please go ahead.
From Eastern Visayas. Dr. Ludina, go ahead po, ma'am. What is your final message to our audience?
Short message lang po.
Okay, for the regional office po, very important po yung early detection ng disease. Kasi we have seen na, like for example, if the history is not complete and the physical examination is not thorough, nami-miss talaga. We've seen cases na nami-miss talaga because walang fever, hindi reliable yung informant, so nami-miss yung mga details na dapat sana ay naitatanong and natitake note. And also very important din yung we encourage the early consultation po of our cases or our patients kasi doon nagpi-play yung role ng nakikita natin na may mga poor pa din ang seeking behavior ng community. And also lastly is we really advocate na yung ating community ay alam talaga ang basic on dengue, dengue facts natin, and also yung ating mga clinicians are trained on the management of dengue. Thank you.
Thank you very much, Dr. Ludina. And let's go to Albert. Albert, what's your parting message?
Thank you, Doc Susie. Primary health care. Yan, yung sinasabing primary health care, napagpapalit siya sa primary care. Yung sinasabi na early detection, early consultation, nangyayari po yan sa unang-unang tao, first contact na makakausap ng pasyente. At kung ang makakausap ng pasyente ay hindi alam kung ano yung mga signs and symptoms o kaya ay walang patutunguhan, meaning alam niya na, recognize na, pero wala siyang maiturong ospital, doon tayo nagkakaproblema. Kaya nagkakaroon ng complications at yung mga nakikita natin ay mahirap nang i-manage. PhilHealth comes in this time around with the outpatient benefit package, ang tinatawag natin ngayon na konsulta. Amin pong inaanyayahan ng lahat. Alamin natin kung nasaan ang ating mga konsulta provider, mag-register po tayo. Para sa mga doktor, join the primary healthcare campaign through konsulta, magpa-accredit po, mag-register ang lahat ng mga pasyente para matugunan natin yung ating sinasabing first contact point of care para sa dengue. At alamin natin yung 4S, huwag natin kalimutan, it's a together campaign, di ba? Hindi ko na dadaanan sa DOH na yun, pero yung third S, doon nakatutok si PhilHealth, seek early consultation. Thank you po.
Thank you so much, Albert. And on behalf of the University of the Philippines and all our teammates and colleagues, we'd like to thank our speakers for being with us today.
Thank you so much.
Next week, join us. Also, special thanks to Jing Solante, who had connectivity issues, but please go back and watch the presentation, the whole webinar, on the playback. Okay, so next week, please join us. We have the Department of Anesthesia. They are going to present the latest in anesthesia that they're doing at the Philippine General Hospital. We're going to have the head, Dr. Grace Herbosa, who you've had before. And we encourage you to invite others to please attend the next webinar of Stop COVID Deaths. Go ahead, Raymond.
Thank you so much, Dr. Ludina and Dr. Albert and Dr. Susie as well. Before we conclude our program, we'd like to remind you that all Stop COVID Deaths webinars are archived for viewing at the TVUP YouTube channel, as well as our SCD shorts. You just need to type into your browser or in your application, www.youtube.com/TVUPPH. And that formally closes our webinar for the week. Makita-kita po tayo again next week from 12 noon to 2 p.m. It's a date.
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online.